So it's my great pleasure to introduce Dr. Lauren Treat. She's a child neurologist and pediatric palliative care specialist in Denver, Colorado. Her clinical and research and education emphasis is on trying to build interdisciplinary palliative care for children. So the perfect person to start us off. And Lauren, could I just welcome, thank you very much for being here. And can we just start by asking you a general question about to describe the current state of play of child palliative care?
Yes, thanks so much, Ed. I'm so happy to be here. Pediatric palliative care has followed on the heels of adult palliative care to a large extent over the last many years. And I think it's important to recognize that in pediatric palliative care, the majority of children seen do have a condition that it kind of includes some sort of neurologic liability. There's a high degree of children with motor and intellectual disability. And when we look at the broad picture of who's being served by pediatric palliative care, the top categories as far as diagnostics go are the ones that are genetic, metabolic, congenital, things that have happened from a very early age or often have had onset during childhood, obviously. And then oncology, the oncologic processes actually fall much farther down on that list. And so when we're thinking about pediatric palliative care, it looks different just as far as who's served in that population compared to the adult side. And so neuropalliative care, pediatric neuropalliative care really has such a home within pediatric palliative care. And there's a small number of us child neurologists who are doing this work, but there are a lot of pediatric palliative care doctors who consider themselves specialists within these neuro-focused realms because of those diseases that we see, a lot of those rare genetic diseases that are involved in this cohort of kids. And so I wouldn't say at all that while I think most of the children that we see in a pediatric neurology clinic are eligible for pediatric palliative care because they have life-altering and in some cases life-limiting diagnoses, I wouldn't say by any point that the overlap is super high right now in terms of the people who are actually served. And I think that comes to the workforce shortage and a lot of the misperceptions about palliative care too. So we have a lot of opportunity to bring this forward and to help make it more robust into the future.
Thank you. And I guess that started already to draw on some of those key differences and similarities with adult neuropalliative care. Would you like to go into that a little bit for us?
Yeah, that sounds great. So again, thinking about the difference between those two categories, adult and pediatric, a lot of children with complex chronic disease have been living a life of high fragility or high complexity over the course of, sometimes it's in early life in the neonatal period, hours to days, sometimes it's been months to years, sometimes it's even decades that these children have lived in this kind of medicalized situation. And so there's often multiple subspecialists involved in their care. When a neurologist is involved, there's often also a pulmonologist, also a GI doctor, also a rehab doctor. And so as compared to, I think a lot of adults see plenty of subspecialists as well, it's really the norm for kids to have a lot of subspecialists involved in their care and to have to do a lot of this care coordination work, as well as to try to help families hold this big picture view. That's really a place where neuropalliative care can shine, is to say, okay, we have all of the subspecialists' opinions, but let's also talk about the 10,000-foot view of how all of this is going and try to get perspective really on what's happening here and kind of mark some of the time that's passed, because time can do really weird things when you're in the hospital and when you're constantly coming back and forth into the clinic. And so it's a really important piece for palliative care to hold. A lot of families tell us, well, when I have a problem, I have 6 different clinics that can tell me what it's not, but I don't have anyone who can talk to me about what it is and what we should kind of do about it. And so particularly for these kids who have a lot of subspecialists, to have a person who they can kind of come to and step back and observe the whole picture, that can be really helpful as well. I think the other big piece is that these kids have a high degree of dependence on medical technology, which obviously that happens in adults as well, but I think there's a really high proportion in the pediatric palliative care cohort that have G-tubes, trachs and vents, do a ton of respiratory therapies at home, some that are on a lot of other technologies as well. And there are really, really rare long-term care facilities for children. So most of that care burden falls on families. And so the emphasis of caregiver support in pediatric palliative care is huge. Parents are obviously the default decision makers for their children, but to acknowledge their high level of caregiving is also really important in the context of all of the things that we talk with them about.
Mm-hmm. And so do you often have a relationship that lasts longer than the other subspecialties? You tend to be the person with the longest relationship with these kids?
So oftentimes there is really longitudinal relationships with a lot of these subspecialists, but I think there is a really big need to recognize that these palliative care relationships too are meant to last. The high fragility factor means that children could pass away, in the next 6 months, 12 months, year, but they also could live for another year, 10 years, really, a lot of them in this high fragility state. And so being prepared as a pediatric palliative care team to walk with these families over months, years, and even decades in many cases is, I think, a really different thing from adult palliative care as well.
Thank you. And so could I ask a little bit, so as a geriatrician, I mean, this really speaks to me, right? You're pretty much describing how I feel about geriatrics often. So I wondered a little bit about sustainability, because if you're having a care relationship that lasts for a decade or more, then how does that affect the sustainability of the specialty?
Yeah, absolutely. So I think a lot of that goes into how you set up a clinic, right? How would you set up something that's built to last, that's built to have the right infrastructure so that you as a provider or as the team, ideally the team, but sometimes it's just one person, are getting to serve the people the way that you want to, and to be able to have the things be able to triage the way that they ought to, make time for those important conversations, have the right cadence of scheduled visits, but also time for when those decision-making things come up, or when the tides turn in the course of an illness. And so that's been something that I've really worked on within my own clinic, is trying to find the right model for how often people need to be seen, how to stay connected in that relationship, build that therapeutic alliance, while also finding a way that I can get through the amount of referrals and try to find the right amount of support. How do you train your social worker, your spiritual care provider, your nurse care coordinator to have to be empowered to take on the amount that they can, while also knowing when to kick it up to the provider level, things like that. I think that sustainability factor is really important with regard to how you design your team, how you design your clinic, and how you plan to address things. A lot of that is expectation setting with the families about what you plan to, how quickly you plan to respond to messages, so that they're all clear, and that when they're in distress, they want to know that someone can be there for them. And so understanding that you will utilize a team approach, that you will, help triage their needs, and that you will partner with them into the future, I think, to me, is a big piece of that sustainability for a clinic and a relationship over time.
Fab. Thank you. So how do you, I'm wondering about the stepping in points and the stepping off points. So I know that people have described a sort of simultaneous care model where you'd be involved right from the time of diagnosis. Is that something that you do?
Yes. So I think the workforce in pediatric palliative care is more limited than we wish it was. And so I think there is a future state that we can realize where there is palliative care available from the time of diagnosis in these serious neurological conditions, a lot of them genetic, metabolic, neurodegenerative sort of things. My model has been to meet them whenever that opportunity arises, whether it's at diagnosis or when there's a decision that's being made or something like this. And then again, expectation setting comes up here too. Be able to say that we're going to work closely together over this set interval, so that you come to understand me, I come to understand you. And then we're going to base our frequency of visits on how stable the condition might be for the child. And again, recognizing that chronic fragility piece, knowing that there will be something that comes up that's unexpected, that we have bandwidth to accommodate it in these ways, but the plan will be for usually, every 6-month check-ins, potentially something like this, unless things are feeling unstable and there's more need for frequent touch points. That's been kind of my practice.
Thank you. And would you ever, so it's a very responsive model, isn't it? And requires frequent review, I guess, of individuals' cases. Would you ever use tools at all to try and to screen, or to to periodically check in that sort of systematic manner?
Yeah, that's a great point. There are needs assessment things. There are fewer kind of validated tools on the pediatric side, again, because we're just lagging behind a bit. But that can certainly be implemented and help with some of that triage that you can do, also to help understand which member of the interdisciplinary team is best suited to answer those kinds of questions, right? It might not always be the physician. And while people are used to interacting with the physician, having the physician kind of be attuned to how the interdisciplinary team can really best fit for the family's need could be part of that needs assessment tool. So I think that those have a lot of potential for helping set up and helping to continue a clinic to run into the future. It's not something that I have integrated into my practice eventually, but it's an aspiration.
Thank you. So we're going to hopefully have a chance to come back to this. And at the end we'll have questions, so we can draw out some of these points a bit further. Just in our last minutes, I wonder if you had any top tips for people who are looking to develop a service?
Absolutely. So in setting up a service, talking with your stakeholders, trying to understand what they know, what they think you do, what you think you do, and how those things all can kind of align. I think the biggest thing for success for me has been to develop a routine, or develop, very clear set of expectations. For me, I've tried really hard to give my referring partners, my neurologists, my hospital medicine people, clear language about not having to stumble over the words palliative care when they're introducing this. I call my clinic quality of life clinic, because I just try to really be as unenigmatic about things as possible, but giving them that language. And so saying, for my group, it's saying, just like you would introduce a headache specialist or a seizure doctor, say, we have a child neurologist who specializes in palliative care, or who specializes in quality of life, just like we have a child neurologist who specializes in seizures, and kind of trying to routinize it that way can be really helpful. And then also trying to give them very clear referral criteria, or saying, like, these are the times when it's best to introduce this kind of support in the context of a serious illness. Yes, diagnosis would be a great time, but also the referral criteria that I've given my group is for children who have presumed or confirmed genetic conditions, or an acquired brain injury, like in the neonatal period, or traumatic brain injury, and that they're facing some sort of anticipated decision, whether it's placement of a G-tube, or consideration of trach vent, or consideration of even a clinical trial. But giving them that language and giving them that leg up about how to think about how to conceptualize of the clinic and how it fits in with their work has been really a key to success for building my program.
Fabulous. It sounds brilliant. It's wonderful to see your passion for it. It's fantastic. Very, very last point then, dream development, one dream change.
Yeah, for me, it's the workforce issue, just because, it's a little lonely out here sometimes doing pediatric palliative care, because it's just, it's coming into its own. I have all the faith in the world that it will be part of the future of pediatric medicine, but it's a little bit few and far between. And especially for our families who don't live at a major metropolitan area or near a freestanding children's hospital, the teams are a little bit harder to come by. And so my dream is for the workforce of pediatric palliative care, and specifically pediatric neuropalliative care, to come into its own and to be able to serve the children across the world, really.
Super. Thank you ever so much for your time. That's absolutely brilliant. Remember, please, to put your questions into the question box, and we'll be able to circle back to those at the end. Thank you. And we've had some interesting issues raised in the various chat boxes. So one of the issues that people are asking about has been about tools and how do you manage that. So there's a question here from Professor Kluger: what tools or resources do you wish you had as you were getting your clinic set off the ground? So why don't we start with Joel with that one, if that's possible?
Well, honestly, as I think about that, Benzie, I think of your clinic and what you had said in the presidential address. Getting out and seeing how other people are doing it was very helpful for me. I think having the support of administration was very important for me as well. I was blessed enough to have those resources available to me. So I kind of felt like I had at least a good starting point there. I don't think that there was much lacking for me personally that I can think of right now.
I guess for myself, one of the issues I think we've had, and which we probably touched upon in our discussion with Claire, was this, the volume of people who would potentially benefit from services, particularly in dementia and PD, just far outstrips the capability of services, structured services, to try and meet that in the UK at the moment. And so I kind of feel like we're trying now to retrofit ways of identifying people in a fair manner, of triaging unmet need and making sure that we can try and address it. And so I guess in an ideal world, we'd have thought through some of those issues that would have been there before. So I think we'll answer those questions. I think we're answering them, and for people developing services going forward, I think that will be better for that, trying to build in those aspects from the beginning. Anyone else have any thoughts about that?
Just to echo some of those comments, really truly getting to build on what other people are doing is such a gift. And now that we are all coming together to have these discussions more formally, I have so much hope that the iterations will get better and better as we're going along. So the importance of having those cheerleaders, but also those examples in the past of what has gone well and what hasn't gone well, and being really honest as a field about those successes and failures, it allows the next person who's getting their clinic off the ground to tailor it in a way that it might be more successful. So I think this is crucial.
Thanks, Lauren. Could I draw on one of the earlier questions from the chat? There's, I think I'd be really interested to explore the differences here between North America and the UK. It's a question regarding spiritual care and chaplaincy. And I'm sorry that wasn't drawn out much in our discussions, but let's do it now. So I think this is a real weakness in the UK. I think it's very rare that we have, I'm not aware of a service that has a chaplaincy service embedded in it structurally for this type of care, as opposed to sporadically accessed. What's people's experience of utilising chaplaincy services and doing that well?
Well, I would say for us, that's really our next step that we're planning on doing. We've been in discussions for a while. We've got some chaplains who are interested. We're in the process right now of discussing what that could look like, whether it would be something where the chaplain would be regularly down there, or could do more of a telephone follow-up later on. Interestingly, as we've gone through some of these discussions, is the chaplain would be there more for the patients and the families, but requests have really been coming from some of the providers as well. And I think addressing that spiritual aspect that we as providers are facing as we are providing for this care and getting into this relationship with these patients, it becomes just as important for us to recognize that in ourselves too.
How about you, Lauren? Do you have chaplaincy embedded in the service that you offer? I guess there are even more challenges there for teenagers and young adults, and spiritual aspects might be even more complicated.
Yes, ever since I've started my clinic, I've been on a huge lobbying effort to get my spiritual care providers to be able to be supported, to be there with me. Haven't been successful yet, but I'm not backing down. As a fellow in Benzie and Christina's clinic in Colorado, the adult neuropalliative clinic, Ryan Kahn, the chaplain, is an integral member of that team. It's a great team, so many important members, but spiritual care specifically in that team, I think it showed me as a fellow when I was there consistently that spiritual care is this ingredient that people don't know that they need, but is so important. And it really is one of those secret sauce sort of things that people leave being like, what was it about that experience? And it's that ability to be human, that ability to have those existential questions sanctioned, or discussion about coping, discussion about how do you make meaning of these things that people don't generally get to do in the context of their medical visit. So bringing that forward and allowing people, not forcing people, not saying that this is necessarily always going to be a part of what you do, but to give them an opportunity to bring those really, really meaningful aspects of their disease and their coping and their humanity into their medical care is an incredible opportunity and such an important part for our spiritual care people to partner with us to do.
Thank you. Claire, can you unmute?
Yeah, I can add to that, because it's work that we're doing at the moment and work that we're really thinking about in terms of how we conceptualize spirituality in dementia care. So as part of the Embed Care program, we're now trying to identify what is spirituality in dementia care, and also what's out there to support people in spirituality. So in the IPOS-DEM, we've got a question about whether somebody's at peace, and that generates a whole lot of different interpretations in itself. We wanted a spiritual question in there, but people interpret it very differently. And then it's what is spirituality, and how do we manage that in dementia care? So it's ongoing work. There's not very much out there in the literature at the moment, and I think it's a huge gap in what we do, but it's something that we're looking at addressing as well. And certainly in terms of kind of clinical services, I know in some of the UK hospices, they do sometimes, some of them do have chaplains. So that's not necessarily uncommon, but they would be much more in the specialist services.
Yeah, definitely. Sorry, that's what I meant. I mean, I think all hospices would have access to spiritual support. And once you're in that service in the UK, you could access that in a structured way. The trouble is, most people who have neurological disease will be accessing their palliative care through folks like ourselves, rather than specialist palliative care. And even so, for my service, we'd take cases to an MDT, and then we'd refer from the MDT to focused hospice services, so you could potentially access that. And just to be up to date and mention COVID, because you can't have any sort of conference without mentioning COVID. COVID's been a real challenge because those services have all gone online. And so for older people in particular, but also folks with diseases like PD, it's very, very difficult to try and access online spiritual care. And especially in a society where we are really not good at talking about those things, to do it with an internet barrier in the way, I think is very, very tricky. So certainly it's an area that we're trying to desperately address. So time-wise, obviously things have been a bit disrupted by the technical issues, but we're going into a long break. So I think I've been told we're happy to carry on talking while there are interesting questions. So I hope that's okay. And the panelists can fire me rude messages if they don't want to speak anymore. There's some interesting points in the Q&A about transitions. And the first one really is about transitioning in your setting, Lauren, from child to adult or young adult neurological services. And so I'd love it if you could talk to us about that. I think also maybe we can expand it afterwards, because there's a second question about transitioning from neurological care to neuropalliative care, and whether you need separate providers for that, and the challenges of trying to be a single provider doing that. So I think, although the original question was about pediatrics, I think this idea of transitioning between different specialties actually is probably wider. Do you want to kick us off, Lauren? Yeah,
happy to. Transitions is a huge focus in young adult populations, many of whom have these complex chronic conditions. And for me, what I found, a lot of it is institution specific, what the institution tries to do with their populations, because if all of their other subspecialists that I talked about are going to stay at the children's hospital, it's way more sanctioned than for them to also get their palliative care there. And in fact, it's a help, right, to all those other subspecialists to have that extra layer for the providers and for the families in those discussions at that same institution. For a lot of the other families that are transitioning over, adult neuropalliative care is available in my city, so I'm able to sometimes get them over to that clinic, and also really help crystallize what it is that they are bringing forward with them. That's kind of a task that I really see as important for myself in that handoff, whether it's just to those adult subspecialists or just to other, palliative care doctor too. But what has it been about that narrative, about that history that are the salient points and those value-based goals of care, and how do those affect the decisions that they've made recently or the ones that they're worried about making in the near future. To that question about primary neurologist and palliative neurologist versus combo neuropalliative care provider, I have the same feelings as Dr. Foster Barber, who wrote in the chat here. It is very hard to take both roles on, and especially as you're establishing yourself as that palliative care doctor, someone who's new to the team. Sometimes you get more buy-in if you are doing that primary neurology too. So for some families who are skeptical of what's going on, you can get your foot in the door more by giving them more of that neurology, less visits, work. But for me, I found that that's really only possible for me to combine well when there are limited amounts of neurological needs. So if they have well-controlled seizures and I can keep them on their Keppra or something like this, I'm fine to be the neurologist in that situation. But if there's a lot more diagnostic stuff that needs to be done, I find that it muddles the conversation. I really like to play that card sometimes of what did the other doctor tell you about what to expect? What did they help you understand about the future of this? And to be able to be that neutral third party goes away a bit when you try to fulfill both roles. And I think that's to the detriment of the overall relationship sometimes. Certainly value, when you say I am a neurologist like that other person that you see, you get some more buy-in too for that reason. And so I've found it most helpful to keep those roles separate until that advanced stage when you are doing that high symptom management and high degree of palliation. And getting to the clinic is harder and harder. That sometimes becomes the point where we do transition over fully, but I try to keep them separate otherwise.
That's really interesting. Unsurprisingly, I have comments because I talk too much. Joel, come on. What's your observations there?
Well, I appreciate what you're saying there, Lauren. I'd have to echo, we're doing a lot of the same things where even from the get-go, I'm identifying myself as the neurologist who practices palliative care. And you have your neuromuscular doctor who specializes in ALS or the muscular dystrophies, to try to separate that role a little bit so they know who to turn to as well. When there's questions about this, maybe it should go to the neuromuscular doctor versus it's more of a question about symptom management, maybe going more towards me. But I'm right with you there as far as kind of acting as that neutral third party. Sometimes when you start doing the diagnostics, it does get a little bit muddy. I do have probably a handful of patients who have said, will you please be my neurologist as well? And I'm happy to take that on and kind of do that dual role for them. Within my own practice, what I found is just talking with the referring doctors is very important as far as trying to determine when are we going to make that transition? When is it time for that primary neurologist to step back? When is it time for me to step in as the palliative neurologist taking over more of the care? It's usually a phone call, a text. In that same sense, I'm also talking with a lot of the hospice organizations or the community palliative care organizations in the area, really to partner and collaborate and say who's doing what for this patient. And that open communication and that case-by-case basis is what I found has worked best for us.
Thanks, Joe. So it's interesting. I guess my experience is different. I'm maybe earlier on in providing this type of care. I come from a geriatrics background where we're used to kind of muddling along a bit, maybe, I don't know. So in the UK, I don't see, and correct me, Claire, if you disagree, I don't see a model where we will be able to have those distinctions effectively, except for a small handful of people. And if we are to try and roll care out in a more structured manner, it's going to have to be done. A lot of the palliative care is going to have to be done by non-palliative specialists. Now, we don't have the same training routes that you guys have, where people can dual accredit formally, and maybe we need to do that. And we're looking to set up a fellowship in the UK, in Bristol, to do that. But we do have a very strong tradition of geriatrics in neurological conditions, particularly for PD, and therefore there's a strong palliative care element to our training. And so my experience has been different, whereby actually, if, you know, the way it works with the hospice is that I can refer them specific things. And I've been really lucky that some folks have joined me to make an MDT where we can discuss issues. But realistically, that needs to be probably 5 or 10%, probably 5% of the folks of the issues that we're dealing with. And if we go over that, we're going to swamp services, and hospices won't be able to offer that to us because there's too much other work. And so actually my experience has been different, and we do try and do those things. And I think in some respects it's been helpful. I guess you'd have to ask the people who come to clinic. I think in some ways it can be useful to be able to have that insight into their other care and to have that relationship, and to be able to broach some of those issues as we move through their disease process. And the way that we deal with it is that we have I have two types of clinics. I have a normal clinic. We don't call it normal clinic, but the regular clinic. And then we have a supportive care in Parkinson's clinic, so skip clinic. And so the idea is that myself or my colleagues who are in their regular clinic can then recognise an issue, park it, and say, come back to this other clinic where we've got more time to deal with it. Because we introduce that to try and get over the missed upward inflection. You know, the greatest case that Sherlock Holmes never investigated, where doctors and other specialists miss those cues because they don't have the capacity to respond to them. So that's what we've tried to do. So I guess it's, you know, it's different approaches, and I'd be really interested in, you know, I think it feeds in a sense, I guess, to the next part of the questions that we've had, which is about heterogeneity and how do we deal with heterogeneous, I can't even say it, models of care, right? So we're all trying to do our best. We're describing very different ways of approaching the problem. So how do we deal with that heterogeneity, do we think? Claire, you may have some views on this, given your interest, particularly in tools.
Yeah, I'll just pick up on the last point as well, and then kind of, because that leads on quite nicely. I mean, I think just in terms of the older population and the population with dementia, there's just such huge numbers, is how we address all those care needs as well, and many don't fall under any one particular team or under no team, or just under a GP. And so addressing kind of and identifying all those for palliative care is really, really challenging. And then all the services look really, really differently. I mean, I think it's aspirational and unrealistic to think that we're going to certainly in the UK, remodel care, that all the services are going to look the same. That's not going to happen. So I think what we need to do is find and test models that are adaptable and that can work. And I think, again, coming back to the point that Ed made, is that, you know, many of our population will not see specialist palliative care. And so the aspiration that palliative care becomes everybody's business, I think is an important one, particularly when we've got a growing population of who've got need. So again, when it comes to tools, I think tools are good and easy ways of skilling people to identify those who at most need of palliative care, and identifying those who need it and those who need referral to more specialist services. I'm also very mindful that many of the population live with a very uncertain trajectory, and often we're managing two aims of managing symptoms, but also optimizing people's well-being and function as well. And that managing those two together are really, really important. And so it's about kind of identifying those palliative care needs, but also optimizing well-being and function and independence as well, even in the face of a life-limiting and deteriorating illness. So I think tools are a way of being easily implementable across any service and within any service, because it's not overhauling a system, and it's a way of providing a language across across services, particularly for those who are not skilled in providing palliative care, but also those who are not clinically skilled. I mean, a large part of the workforce are untrained carers who are providing personal care, but are actually really, really important in knowing the person and seeing the day-to-day changes and seeing when important changes are occurring, but they don't have the language to communicate to a GP that actually something's going on, but they don't know what and how they can escalate that in the right way. So I think we need to look at services that are sustainable and implementable and scalable, rather than, yeah, as I say, overhauling a whole system, which seems impossible. But I'd welcome colleagues' perspectives.
Thanks, Claire. So I think we just have 2 or 3 minutes left. And I just wanted actually run through your point to draw on one of the other questions or comments in the Q&A box, which was around utilising and drawing on the huge body of skill and experience in non-doctor, non-clinician groups. And I'm sorry if it didn't seem like we were doing that. I guess it's difficult to cover everything in short interviews. I'm pretty sure everyone would like to. And I suppose the question is, how do we best draw on that body of experience? And how do we do that in a structured way, in a way that supports those people and that allows a two-way relationship between them and the clinician providers? Let's start with Joel. Sorry, I keep not directing my questions to people.
I would say that I've got a great partnership with our social worker, who again is embedded right within the clinic. So there's no formal sort of setting where we say you must see the social worker X amount of times, but I find that having her there and available, I step out of the room and one of the first things I'm doing usually is going over to her to talk about the case, kind of addressing some of the needs, and oftentimes she'll be able to pop into the room and talk with the patients about things that I wouldn't even be able to talk about myself. So I'd say in my personal experience, I utilize that social worker quite a bit. Within the ALS clinic, because of the nature of those being multidisciplinary, we've got access to the respiratory therapist, the speech therapist, the physical therapy, and the list goes on, but even dietary. Having the model that's already established within most ALS clinics in the country really allows for a lot of those kind of non-doctor providers to be able to collaborate with us. We talk about all the patients, their needs, what our interventions are, and oftentimes having all the disciplines at the table really helps us provide the best care, but really helps to improve the functionality and living day to day. So I find that both of those things have worked great in our clinic.
Thank you. Lauren?
Yeah, I think of what you're getting at, Joel, is having a standard of care. You know, like in an ALS clinic, there is now kind of this established standard of high quality neuromuscular care. And that's what we're endeavoring to do too in the field of palliative care. I mean, the national consensus projects for high quality palliative care are taking the research, they're taking the clinical experience, and they're trying to say, now what is the standard of care and how do we then get that to be something that changes the system, that helps us. There's questions in the chat too about advocacy and this being a right for all humans to get high quality whole person, care. And that is where we all want this to go. And part of it is going to be our own like cognitive organization around what I do, what my spiritual care partners do, what my social workers do, how I structure my individual visits. But it's also getting that systems level support for people to pay for you to have a chaplain, to get something in place where you can have access to a social worker, just like hospices do, at least in the US. There's this core set of people that have to be on a hospice team. If we could be able to change even just our clinical infrastructure on inpatient and outpatient sides to say palliative care must include these other domains of service in order to be the high quality care that we want it to be, that's kind of pie in the sky, but that's where we all hope that this will go, because that's what we need. That's what we want patients to be able to realize and to benefit from overall. So I think a lot of it is, you know, the systems level as well as the individual practice and orientation.
Thank you ever so much. I could talk to you guys all day. You're super interesting. I'm really grateful for you sharing your expertise, and also for the people listening for doing so. There's lots of interesting things in the chat if people want to look through that. And I'm sorry we haven't managed to get to everything. Thanks ever so much for your time. Enjoy the rest of the conference.